echo that we would start at the beginning. So this presentation will really be a general utility of pharmacogenomics, looking really at two different aspects. And the aspects are efficacy/inefficacy and then adverse drug reactions. So when we think about a population of patients, certainly we understand that they have many differences that are included in their individual cells, right, within that population. But from the therapeutic standpoint, we're looking for patients to have efficacy with minimal risk of toxicity. So when we think about the overall population, if you look at this figure, and this is a popular figure used many, many times, you see a number of different individuals with a common diagnosis that might need pharmacotherapy. And so we see from that aspect, subpopulations, hopefully most of them will have efficacy with no toxicity. But we also know that we have patients who have inefficacy. They don't respond to the medication for whatever reason. We get into trial and error method, right, of dosing and drug selection. And we might have a population that has adverse drug reactions. And so there's another component that we have to think about. And of course, you could have yet another population, not on this slide, where you have somebody who has inefficacy, but also experiences adverse events, I guess the worst case scenario. So I'm going to focus on the metabolizing enzymes and metabolizing phenotypes. And so there's been, within the last number of years, some standardized terms. And you can see this figure here with the 5 different curves. And you can see the table embedded in the figure that shows the ultra-rapid metabolizer in green, the rapid metabolizer purple, the normal metabolizer, which will be compared to mostly in this talk, as the gray, the intermediate metabolizer in orange, and then the poor metabolizer in blue. Now, these different metabolizing phenotypes, I think for the context here with this first echo is to think about this in terms of exposure. And the exposure term that I have on the far right is the area under the curve. So you can see quite a bit of difference between these different metabolizer phenotypes. This was a modeling exercise that was done with some data. And you can see, for instance, the exposure from an ultra-rapid metabolizer considerably less, about 7-fold less roughly from the poor metabolizer on the other end. So let's dig into this a little bit deeper. So this figure shows the percentage of patient population for which a particular drug is ineffective, and this is on average. Now, this data is a little bit old, but I think these numbers are still holding some, pretty close to what they are. So we see on the x-axis antidepressants, asthma drugs, diabetes drugs, arthritis, Alzheimer's, and cancer drugs, right? And we see then the percentage of individuals on average that don't respond to medication within a given population that receives those medications. So we see a significant number of individuals who don't respond. And again, that puts us down the path of trial and error. If they don't respond, what are the consequences of that? In our case today, we have a behavioral health case, and they can be very dire, the consequences of somebody not responding, say, to a medication for major depressive disorder. So we need to think about how may pharmacogenomics impact these numbers, along with all the other data that we use when we consider patient drug therapy. So let's look at this from this same image we had earlier with the ultra-rapid metabolizer. Now, this would be the individual who's receiving an active drug. And we look at the green curve. This is the focus of this slide. We see the ultra-rapid metabolizer has very little area under the curve relative to both the normal metabolizer and other metabolizers. The point is that this decreased area under the curve, this decreased exposure, can be related to inefficacy and failure of pharmacotherapy. So how may pharmacotherapy, again, be impacted by including as a piece of the overall information the pharmacogenomics of that patient? Now let's look at the other end of things and look at the adverse drug event reports. This figure is taken from the FDA adverse event reporting system. Now, I don't want to give the impression that all of these are adverse events that can be taken care of by considering only pharmacogenomics. There's many things that are involved here. So certainly we have the post-World War II baby boomer population. They're an older population, so you can have decreased physiology, which will affect drug elimination and then exposure to the medication. And of course, if they're getting a medication, well, it's likely because they have a pathophysiology. And if that pathophysiology entails decreased renal function and or hepatic function, then again, those two major eliminating organ systems that get drug out of the body, those being decreased, that could also result in increased exposure. And then we have the fact that they're taking multiple drugs, so drug-drug interactions, which we're used to dealing with. And so there's a number of things that result in adverse drug events, but what component of them may be pharmacogenomics? And we see in the embedded table for serious adverse drug events and deaths, these numbers are going in the wrong direction over the last 5 years. And there's a number of reasons for that, as I said. So again, I think what we have here is a way to look at this from exposure. And this is the last time we'll see this slide, but this is the same slide we saw twice before. Now we're looking at the poor metabolizer, the blue line. And you can imagine in this concentration time data that is exhibited here, that area under that blue curve is considerably greater than the other phenotypes. And so this person with a poor metabolizer phenotype is at increased risk of adverse drug events, reactions, because of the increased exposure. When you look at the relative number here, 59.4 relative to the normal metabolizer, you see almost 3 times the AUC, or the exposure. So again, in both instances, with inefficacy and with adverse drug reactions, how may pharmacogenomics impact? So let's take a look at some specific examples here. On the left side of this table, we have metabolizing genes, drug metabolizing genes, pharmacogenes. We'll start with CYP2C19. Then we have the genetic part, the diplotype, one from mom, one from dad. And this is the star nomenclature. And I know that we will get into other ECHO sessions where this information is provided in greater detail, like resources and nomenclature and the like. But in this example, we have the star one, which results in a normal metabolizer phenotype. Now, clopidogrel, of course, is a low-hanging fruit drug that we've used as examples many times. It's the prodrug, and so it needs to be converted to the active form. So we would expect that a normal metabolizer would readily convert the drug to the active form, and we would think the patient would have the desired antiplatelet effect, and we would see efficacy in this case. And that's what we would like to see happen. Now, the star 2 form is the case where we have no function allele, one from each parent. And in this case, clopidogrel will not be readily converted to its active form. And so in this case, we're looking at the potential for increased risk of stent thrombosis in the PCI setting, and then inefficacy here with the complications being a myocardial infarction or death. So we have these two contrasting normal and poor metabolizer phenotypes with differences in efficacy, inefficacy in one case, efficacy in another. Now, warfarin is an active drug, and we'll go through this same kind of scenario, but now with CYP2C9. And again, star one in this case represents a normal metabolizer, so we would expect for our patient the desired anticoagulation effect and efficacy to occur. Now, in somebody who is a star 3 individual, that translates to a poor metabolizer phenotype. So in this case, the exposure, that area under the curve to warfarin, would be increased, and the patient would be at increased risk for bleeding. And there we have an adverse drug reaction. So here we're comparing efficacy versus an adverse drug reaction. The final example on this slide is with CYP2D6. And here we have a star one, again, normal metabolizer, the patient receiving the drug paroxetine. We would expect the desired antidepressant effect, notwithstanding other issues. Of course, that's the case with all drug therapy, right? And if we have that antidepressant effect we desire, we have efficacy. Now, a star 4, star 5 individual with CYP2D6 is a poor metabolizer. So again, that increased exposure, and so potential for adverse drug reactions. And now for the first time, the example includes a star 1, star 2 XN individual. This individual has multiple copies of the star 2 form. Now, I want to point out that the star 2 form that you see up above for CYP2C19 is no function, but star 2 form for CYP2D6 is a normal function variant. So it would be multiple copies of the normal function, which increases the individual's metabolism capabilities as an ultra-rapid metabolizer. So in this case, they would have decreased drug concentrations, decreased area under the curve, decreased exposure, and we might experience, for our patient might experience, I should say, inefficacy. So these are examples where we see these actual genetics related to phenotypes and then related to efficacy or inefficacy and or adverse drug reactions. And this final table shows some genes again on the left, the phenotype, the drug, and then interventions, or at least thoughts that are taken, I shouldn't say thoughts, recommendations taken from different expert organizations like the Clinical Pharmacogenomics Implementation Consortium. And again, I know there'll be upcoming ECHO that talks about resources well beyond what I'm mentioning here. So for instance, a CYP2D6 example with an ultra-rapid metabolizer receiving paroxetine, we're going to have the potential for low or undetectable plasma concentrations and potential pharmacotherapy failure. And so there's recommendations in the CPIC guidelines how to approach this kind of patient. And these are all heavily vetted evidence-based guidelines. Another example of one of the first guidelines from CPIC back in 2011, I think, is thiopurine methyltransferases, the gene, poor metabolizer example of a patient receiving mercaptopurine. And you can see the greatly reduced dose, reduce the daily dose by 10-fold and give the drug 3 times a week as opposed to daily. So you can see this direct recommendation from the CPIC guideline. Here's UGT1A1, an intermediate metabolizer receiving irinotecan. And here, a lower dose is required to decrease the risk of the adverse event, the neutropenia that can occur with that drug. And this comes from the Dutch pharmacogenomics or pharmacogenetics working group. Can never remember that one, at least the name. Here's an example of pharmacodynamic. So this is not related to drug concentrations. This is related to reactions outside of the concentration realm, if you will. And this is a person who is positive. That means they carry the HLA-B 5801 variant, receiving allopurinol. And there's a guideline from CPIC that discusses choosing an alternative drug in this setting, because being positive in that case means increased risk of serious cutaneous reactions like Stevens-Johnson's or toxic epidermal necrosis. So that's another example. And then finally, I thought I would put in an example of a transporter. So this is not a drug metabolizing enzyme, but it's a transporter, SLCO1B1, which recently was updated in the PharmD database. We saw information on that this week. It's decreased function, and patients who have decreased function SLCO1B1, they can't use simvastatin into the liver as readily. That drug then is available in higher concentrations to go elsewhere, like the muscle. And so what you need to do is reduce the dose to decrease the risk of myopathy, and that recommendation comes from CPIC. So these are examples of trying to connect the dots from exposure to what we might expect for patients based on their area under the curve and altered pharmacogenomics. Again, in the context of other things that may be going on with the patient. So in conclusion, the utility of pharmacogenomics, these drug-gene interactions, have been shown with supportive evidence-based medicine to improve drug efficacy and decrease inefficacy, if you will, and also helping to decrease or avoid adverse drug reactions. Many guidelines exist. I think there are now 26 guidelines covering 80-some drugs for CPIC, and there's the Dutch group, there's the Canadian Pharmacogenomics Network for Drug Safety, and there's others, including therapeutic area groups like the rheumatology group and so forth. So if you don't have guidelines, then we need to think mechanistically about the underlying relationship between the genetic variants and what does that mean relative to the exposure and the concentrations and what we see with pharmacokinetics and how the body handles medications, and then also pharmacodynamics. And I think to think about this in the context of pharmacogenomics, we can relate this to how we think about drug-drug interactions. So with that, I'll go ahead and end.